Hi, my name is Matt Smith, and this is my presentation on my experience of having my second hip resurfacing, again done by the same doctor, Dr. Thomas Gross in Columbia, South Carolina. I've also done a presentation of my experience for my first hip resurfacing on the right side. So I'll try not to repeat too much from that presentation and focus on things unique to this second experience. So this was my left hip, and it was done on January 18th, 2023, which, as of this recording, was almost 2 weeks ago. Tomorrow will be 2 weeks. My first hip resurfacing was done about 1.5 years ago, June of 2021. So originally, when I did my right hip, I planned on getting my left hip done as well 3 months after doing my right hip. However, Dr. Gross suggested that I waited until the symptoms got worse, got to the same point as my right hip. At that time, I wasn't having very severe symptoms compared to my right. So about 6 months after my first surgery on my right hip, I got back to playing soccer, and that was going really good. But the more I played, I started noticing symptoms in my left hip, pain after playing. Eventually, it started getting to the same symptoms as my right hip, limping for a day or so after playing, and some limping or like abnormal gait while walking. So at that point in time, I got new x-rays and filled out the forms on Dr. Gross's website for the new hip patient. I had to go the new hip patient route since it had been too long since my first hip surgery, and then just waited until I got the call from Dr. Gross, which was about less than a month. And then we got it scheduled. So this time around was this pretty much the exact same as last time. My surgery was scheduled for Wednesday. So we had a pre-op appointment on Tuesday, so we planned to get there on Monday. And this time around, my relative and friend Joe from Ohio accompanied me on the trip. And so I took a one-way car rental from Michigan to Ohio on Sunday, spent the night, and the next day we drove his vehicle down to South Carolina. So we had an easy trip down. I just really want to thank Joe for helping me out for the whole trip. After we checked into the hotel, which you can see the room here, we drove over to Kroger, loaded up on food and drink for the week. Next day at 9:30 was the pre-op appointment with Dr. Gross. So first I had new x-rays taken. I also had a new DEXA scan taken. And I had the meeting with the nurse practitioner, and Dr. Gross. And at the end of this presentation, I'm including a recording of some of the pre-op discussion I have with Dr. Gross. He's, as always, willing to answer any questions and took lots of time needed to discuss kind of what will happen. And then after that, since I already had my crutches and I already had my ice machine and hip kit, that was it for the pre-op appointment. So next I went over to the hospital that's located across from the hotel, and I had some labs done. So I got my chromium levels and cobalt levels taken. This was to have a baseline of these levels prior to having the second surgery. So I didn't have these done the first time around. So there's shows my values there. You can kind of see that the one test actually lists a normal value for metal on metal implants of less than 10. This one is high for the standard range, but Dr. Gross has already gotten back to me and said these values are all fine. And then also I got my testosterone checked, which can be a issue for low bone density. That was also in the normal range. So after the pre-op and labs were done, we pretty much had the rest of the day wide open to us. Joe really wanted to do play some pool, so we found a billiard sports bar called Racks. Lucky for us, when we got there, it was happy hour, which meant free games of pool, drink discounts, $1 tacos. Also good for us was that we got a game of pool in before all the real pool sharks started showing up. About 6:30, everyone coming through the door had their own carrying case for their professional pool sticks. It turned out to be like a pool league. So it was a lot of fun to watch them play. They also had free darts, so we did a little bit of that next. And got to play some of our favorite tunes on the jukebox while enjoying some wings with devil's blood sauce, which was delicious and thankfully not as spicy as we first feared, and had a little blue cheese dipping sauce there. So overall, we were lucky to find that place. Good place, highly recommended. Everybody there was super friendly, and we had a lot of fun. So that was the rest of our Tuesday. So that night, I followed the rules: no eating or drinking after midnight. Showered the surgery location with the special cleanser they give you at the pre-op appointment the night before, and then you do it again the morning of. And so it was a really early morning. We were scheduled to arrive at the surgery center at 6:30. Once I got there, I had to drink an orange boost drink, just like last time. And then Joe and I picked our lunch options. I picked the tuna blast, which was delicious. And then headed back for surgery prep, which was getting blood taken, taking all the medications, and meeting with anesthesia. So surgery went well, no issues. Once I woke up, the only thing that kind of delayed things was I had low blood pressure, so I had to wait till that got back to normal before I could get up and do the training with the crutches. And if you watched my first experience video on the right hip, you'll notice that I'm wearing the same lucky NFL shirt that I brought to wear after my first surgery. So the walk around went great. Everybody was helpful. And here is a paper copy of my x-ray that they provided me, just a picture of it from my camera. They also provide you a CD as well. Here's what the bandage looks like. It's pretty much the same as it looked last time. They've got the smaller bandage, which covers up the hole for the device that they put in for checking leg length, and then the main bandage over the primary scar. So after crutch training was done, Joe brought the car around. We headed back to the hotel, and there we just spent the evening relaxing, watching movies, which was interrupted by frequent urination breaks. Almost felt like almost every 10 minutes or something. Also got to finish off the second half of the delicious tuna blast sandwich you see there. I will say that this time around, the leg that was operated on, my left leg, felt much stronger compared to my first operation. I'm not really sure why, but after my first operation, it was extremely difficult to get my leg to even move when doing exercises. But this time around, the leg felt much stronger and felt like it improved a little bit more quickly. Also, it was just overall easier since my good leg was my right leg, was my primary leg. So later that evening, the nurse came by, checked up on me, no issues there. And so next morning, Dr. Gross stopped by, gave me the green light to head home. So after Joe served me some breakfast at the hotel, we hit the road to head back to his house, which is a 7-hour drive. We stopped about every hour or so at rest stops to stretch and go to the bathroom. Also did continued icing on and off in the car using the icing machine. And I was still on the long and short narcotics at that time. So I spent the night at the Wolf's and then just spent the next day relaxing, resting, started my exercises. like I said, this time around, exercises seemed easier than the first time around. The hamstrings and quad muscles just seemed to be a bit stronger. So then the next day, on Friday, my mom drove down from Michigan and spent the night at the Wolfs. And after that, my mom drove me home the 5 hours back to Michigan. I didn't really have too much pain on the drive. I stayed on the short and long pain medications. And then once I got home, stopped taking the short pain medication. And a couple days later, stopped taking the long pain medication. So now this is just me leaving the surgery center, getting into the car for the first time. The rest of this presentation is just some extra video clips and sound clips I have. So hope you enjoyed the presentation. Here's, again, me getting into the car.
Nice. And that's how it's done.
Okay, and the next one here is, I believe, me before going back to surgery.
Hey, you recording?
Yeah.
Hey, everybody. Getting ready to head back. Feel pretty sleepy. Looking forward to it, though, and just want to say hi to everybody back home. See you soon. Joe's been taking good care of me, and everybody here has been doing a great job. So, it's been a good first start. I've enjoyed it. So,
Great.
see you soon on the other side. I'm looking forward to my tuna sandwich. What'd you get, Joe?
I got a corned beef and sauerkraut sandwich.
All right. I might have to try some of that. So, yeah.
I'm getting pretty hungry. I might eat yours too before you recover.
That would be awful.
Yeah. You're looking for that tuna blast right now. All right.
So, hi families. Family. See you soon. Thanks.
Okay, and then the final recording I have here is the portion of the pre-op appointment with Dr. Gross.
Again, or you're planning to go over and get it done?
Planning to go over.
Okay, so you have a prescription.
I have a prescription.
Perfect.
We're going to go to the hospital across from the hotel.
Okay, Providence Northeast. Perfect. All right, so and then you can ask me about it. By the time you do your 6-week follow-up, we'll have the results.
Okay.
So the way we normally do this is, and you're probably gonna do it remotely, right? Your follow-up?
Yes.
Yeah. So just put a request when you send your remote follow-up information. Just put a reminder in there. You know, what were my ion levels?
Okay.
You may have already gotten a note from it because I kind of have this automated. So if the levels come back, my staff checks it. If they're in the range that I think is good, they just send you a note saying they look fine.
Okay.
If you don't get a note, that means we haven't received it. It doesn't mean they're fine.
Okay.
It only is fine if I sent you the note.
Yep.
Okay.
Got it.
So just you just kind of check in with me, and if you haven't gotten it, then we'll chase it down and see what the problem is. Sometimes the lab doesn't draw it right or something.
All right.
Or they draw heavy. All right, so your bone density numbers look pretty good. Your lumbar spine's a little low, -2.0. The hips are.
Now these are numbers from last time too, right? Like from because I didn't get a DEXA scan this time.
That's what I was gonna say. I was because you shouldn't be able to get the one on the right because it's metal in there now. So these are from 2 years ago.
Yeah.
I'd like to update it today.
I'm fine with that.
Okay.
They said, they told me when I walked in there, said you don't have to do it because it's already, it hasn't been long enough. It's been like a year and a half. So
Oh, I see. So
it's not a full 2 years yet.
Okay, I guess we
But
can
I'm
go
fine
with
with updating it. I don't care.
okay. And the lumbar spine's a little low, so that's a little bit concerning that your number's minus 2.0 in the back. And you're an athlete, right? You run and jump.
Yeah.
Yeah.
I mean, would it be interesting to do it again? Because
Maybe we should, yeah, just to make sure.
now, were you saying they couldn't do it because of the right?
No, we won't get an accurate number on your right.
Oh, I
Right now
see.
there's metal in there, so it's going to look like you have super bone.
Okay.
Because metal's dense, right?
Yeah.
So we don't ever measure it on the right, but if someone were to measure it, they'd say, wow, you have really strong bone.
Yeah.
No,
Okay.
it's the metal.
Okay.
Okay.
I'm interested in getting it again. If that's
All right,
not-
let's do it again then. Based on your previous number, you're in the FAST program, and you just take alendronate for 6 months, the bone strengthening medicine. You remember that? We did that last time as
So
well.
last time I talked to, I don't know if they got it to you directly, but I think you approved it, that to not do that and to just do the calcium supplement and to do,
Just stay on crutches longer instead?
yes.
Yeah, you can
to
do that
not-
instead.
To not do any activities for a longer period of time.
All right, so the reason we do this, it's a process because we know that bone density affects the fracture risk. There's a risk of femoral neck fracture in the first 6 months. If that happens, you have to be converted to a total hip, right?
Yep.
It means a revision operation and a not so good functional outcome, right?
Right.
Total hips don't function like
For
these
sure.
things. That's the problem. Your risk with the number you have currently is about 1% fracture risk. If I give you alendronate, I can reduce that to 0.2%.
Okay.
So we've got data on this, right? We've done
Right.
this a long time.
Right.
So
For
if
me-
you're choosing not to do it, you're choosing to accept the 1% rather than a 0.2%
Right.
risk.
Right.
Could you just do crutches longer? Probably, but we don't have any data on that, right?
Okay.
So we have data on one thing, we don't have on another. But
Yep.
probably if you go just keep your crutches longer and go slower, you probably increase your odds of having a good outcome, right?
Okay. Yep.
But it's all risk, 1%, right? What is your risk if you do crutches? I don't know.
Right.
Probably a little less than that.
Okay.
If you do it rather than 1 or 2 weeks, more like 6 weeks of crutches.
Okay. Now, I can't remember, but last time, so my mom's a pediatrician, and she looked at some of the side effects of Fosamax, and
Yeah.
she convinced me to just be more conservative in terms of like,
Yeah.
how what are your opinions on
Calcium,
side
there's
effects?
no evidence that calcium is going to help one way or another.
Okay.
Right? So it's just, I think, what we've done is we've tested alendronate and decreased activity on people with low bone density, and we know that the combination helps. We don't know if it's which of the two it is.
Okay.
We just did kind of a shotgun approach.
Can you remind me of the side effects though for alendronate?
Reflux.
Uh-huh.
Very rare instance of necrosis of the jaw, usually with the IV forms, not the oral forms, like 1 in 10,000. That's pretty much it.
Okay.
In over long-term use, there can be atypical fractures of the femur, but it's usually a drug given to older women who are osteoporotic to prevent fractures, and the data is that it does prevent fractures
Okay.
in that population, right?
Yeah.
I've got data that it helps prevent the post-op fractures
Okay.
after resurfacing based on bone density,
Okay.
right? So it's a sort of an off-label use. It's not,
Yeah.
we're not using it to treat osteoporosis.
Right.
We're using the drug for a slightly different use, but showing
And
that it
remind me
works.
how long you take it for?
6 months.
Oh, okay. You take it for the full 6 months. Okay. Okay.
So, what are you gonna do? Are you gonna take the Fosamax, or are you just gonna go slower to keep the crutches for 6 weeks instead of 2 weeks?
I think I'm gonna go slower. Is that something I can change my mind on after I do a little
Yeah, you can.
research? Okay, let's go with
I'm gonna put declined on the alendronate.
Yeah.
And yeah, you can change if you want to.
Okay.
But again, we have data on one thing. The other seems like it would work, but we don't have data. Right?
Yeah, got it.
Okay. And otherwise, your hemoglobin looks fine. Your vitamin D level is still a little low. So, or I don't know if it was low back then, but it is low. So you should supplement with vitamin D.
Yep, I'm doing that.
Okay. So did you start after this test or before this test?
Which I don't know when
The
that
vitamin
is.
D test, when you had your blood drawn by your primary
Oh,
care
just
doctor.
recently. I've been doing it before that. So
All right.
it's
So you're not taking enough,
Okay.
right? So you take. How much are you taking?
I think it was like 2,000 units, and I do it like every other day.
Okay. So you should probably do 2,000 a day.
Oh, okay.
and then check it again in 3 months.
Okay.
So your level's 27, 30 to 100 is normal.
Okay.
And wintertime is when people are the lowest, especially the further north they are. Right?
Okay. Yeah.
Yeah, so bump it up
All right.
and then recheck it. And try to get into the normal range. I try to hit like 50 or something like that.
Okay.
If I were you.
And it'll take effect within 3 months even.
And by 3 months, I'm guessing that you should equilibrate, right? So if you
Yeah.
change your dose, I don't know exactly. I haven't
Okay.
seen any data on how long it takes of changing your dose before your level stabilizes at a new level. So I just say 3 months.
Okay.
And then they can decide if you can go up further or less. All right. You're only 43, and have you ever had your testosterone level checked?
I don't think so.
Okay. Men lose their testosterone gradually after age 30. That's when we peak and we slowly go down. And testosterone can be one of the things that affect bone density. Losing your testosterone is your bone density. One of the things is your bone density declines. Very unlikely at your age of 43 that you're going to have an issue with that. But that's just another thing that my older patients, I tell them to go, guys, get their testosterone level checked, and if it's low, boost it up. Okay, bring it up into the normal range. I don't know if you want to do that. You're only 43.
How do you, is that a blood test or
Yeah,
how do you?
yeah, free and total testosterone blood test.
Should I get it? Will I go over to the hospital? Or?
I can give it to you, yeah.
Yeah, let's just do that since
Okay.
I'm getting. If you think it's a good idea.
Supplementing testosterone is just like in women, the sex hormones. It's very controversial. There's evidence. There's a lot of doctors who do that, who are like urologists or endocrinologists or primary care doctors. They think that if men are low in testosterone, if they give testosterone, they're going to increase the risk for prostate cancer. That's nonsense. That's total misinformation. But most of the medical establishment believes that. Actually, there's a lower risk of prostate cancer in guys who have higher testosterone in their 50s and 60s.
Okay.
Doesn't prove that if you give them testosterone, it's going to decrease your risk, but
there
the
is-
lower levels are the guys that are more at risk. So it doesn't make sense that there's no evidence that giving testosterone increases. It's just one of those things that some of this medical misinformation has been passed along forever. So I just mentioned that to you because if your level is low and you choose to have it supplemented, that's what you're going to run into.
Okay.
Right? You're going to increase your risk of prostate cancer and BPH. It's nonsense. It doesn't.
But there is evidence that increasing the testosterone does increase bone health.
Bone density.
Okay.
And it helps to maintain your muscle mass as you age, right? You're not really in that aging category like me. I'm 62, right? You're only 43. Your levels are probably pretty good still.
Okay.
But your bone density is low, so that's something that that is known to affect it.
Okay.
So you might want to check it, right? You never know where you are with that.
Okay.
What about dietary intake? The other thing that's a problem with bone density is so smoking. You're not a smoker. Drinking a lot of alcohol.
I drink like one a day,
so
usually 5 days a week.
Yeah, so that's very moderate. And a lot of dairy consumption is bad actually too.
I don't do dairy.
Good. All right, so those.
I mean, I do cheese, but I don't do milk.
Yeah, cheese is dairy, but it's also bad for your bone density.
Okay.
But there's moderation, right? Just like a drink a day for 5 days is not healthy, but it's not that bad. So, right? So the same thing with dairy. The less the better.
Okay.
Is probably something to consider. So those are really all the things. And there's certain drugs, but are you taking any medicines for anything?
Just anxiety meds.
Yeah.
Fluoxetine, Wellbutrin.
And those are not known to cause a problem. No reflux medication.
No.
Those cause decreasing bone density.
Okay.
That's been shown. Those and steroids. There'd be no reason for you to take steroids. Okay. You have all your equipment?
Yep.
All right, what else do you want to discuss with me?
Well, I don't know who I'm supposed to discuss it with, but anesthesia.
Mm-hmm.
Whatever they did last time was perfect. They didn't, I was.
Were you done at the surgery center?
Yes, and it was like just a blocker, no catheter, I was breathing on my own is what I was told, and.
Yeah, so we have there's 3 options. You can have general anesthesia, which you didn't have before, and I don't really recommend, or you could do a spinal anesthesia or what's called the lumbar plexus block.
Okay.
So our anesthesiologists are good at doing both of those.
Okay.
I'm not sure what you had last time. They may be able to look that up. With a spinal, we always put a catheter in. So if you didn't have a catheter, you may have not remembered it because we put it in after
Well,
you're under anesthesia.
They told my wife that I didn't have a catheter.
Ah, okay.
So then
it's usually, so we usually put a catheter in for spinal because it knocks out the bladder, and then your bladder gets too overflowed by the fluids we give in surgery.
Okay.
And then we're gonna have to stick a catheter in afterwards to relieve you.
I see.
Because it doesn't work. So with the spinal, our protocol is always to put a catheter in and pull it in recovery when you're still kind of groggy and everything, right? So we're giving the block, but we're also giving sedation. You're breathing on your own, but we're not putting a tube down.
Okay.
But you don't know what's going on. You're out of it, right? You don't remember anything about the surgery itself. But you could also have a lumbar plexus block, and we were doing some of those 2 years ago, I think.
They
so
said they were doing something that they didn't typically do.
Yeah, so the lumbar plexus block will only numb you up like on half the side, and it doesn't affect the bladder so much, so we don't use a catheter for that routinely.
Okay.
So if you prefer that,
If they're able to look up whatever they did last time, it was perfect.
okay.
So,
But those are basically your two block options, right?
Okay,
And
yeah.
discuss it with the anesthesia doctor, and,
Okay.
and you're having it tomorrow at the surgery center, right?
Yes.
Yeah, so you discuss it with them, whatever you want to do is fine.
Okay.
I think the lumbar plexus block is better. We haven't done the full analysis yet, but we've done a randomized control study over the last year on lumbar plexus and spinal anesthesia. And what we've come up with is no difference really, and one of them gets a catheter and one doesn't. We have no high difference in repeat catheterizations while you're awake, which is kind of what matters to people. Mm-hmm. Either one is no different. It doesn't change how long you're in the surgery center and the pain level post-op or anything. We have to give a little more narcotic in surgery with the blocks because they don't work quite as well as the spinal, but then we see no difference once you're out of anesthesia. And there's about a 7% incidence of spinal headaches with the spinals, which is really an annoying thing. So mainly based on that, they're basically very similar is the bottom line, except you have more spinal headaches with the spinal. You can't get a spinal headache with a lumbar plexus block, and that's kind of a big deal. So we tend to prefer the lumbar plexus block now since we've just done that.
Okay. Is it something that when I talk to the anesthesiologist, they'll be able to look it up for me?
They might. I'm not sure. I'm not
Okay.
sure.
Just because I don't know what I'm talking about, so I don't know.
Yeah. Yeah, I don't know. They should be. I don't know exactly how those records at the surgery center are kept.
Okay.
But there was a record at some point. I suspect it's got to be there somewhere.
Okay.
I still don't know. I never looked it up myself.
I'll talk to them.
Our records, my stuff that I do here in the office, I have
Right.
right here, right? But it's a separate system over there. So. Okay. What else?
I think that's it. I mean, the only other thing I talked to about from last time was just constipation afterwards, was my main.
Yeah, we give anti-constipation medicines, right? We'll give you
Okay.
Movantic, and we ask you to get a stool softener and do them both.
Yep, I've got the stool softener.
And if in a couple days you don't do it, then there's some stronger recommendations in there.
Okay. And
Mainly it's the narcotics.
And she said, go ahead and take a stool softener today.
You can do that.
Okay.
You can do that.
No problem. Okay.
Yeah. But take the stool softener and the other one, the Movantic, which blocks the narcotic effect on the gut. But none of these things are perfect, right? You still
Yep.
can have constipation.
And then
Narcotic effect is the main thing that causes it, but there's a lot of ways. All these different anesthesia drugs work in subtle ways that they cause a problem.
And how soon after surgery, should I try and wean myself off the narcotic?
It's usually about 3 or 4 days that people need to take them.
Okay.
So you're taking the Tylenol, you're taking the meloxicam. I've injected you with a local anesthetic that's 3 day, lasts for 3 days. You're icing it, so those are all non-narcotic things we're doing for pain.
Yep.
And then we're giving you the narcotic to take the long-acting one twice a day, and then you take the short-acting one as needed. Once you get home and you go 24 hours without needing the short-acting one, then you drop the long-acting one.
Okay. So the
Then
short acting one I don't even take until I'm feeling something.
Right.
Okay.
Right, and then and once you drop the long-acting one, you'll probably be fine. But if it hurts, you can still take a short-acting one, right?
Okay.
And that's kind of how you would wean yourself off. But usually it's 3 or 4 days. Most people are done with it. Cool. Right? But you got to kind of be the judge of how much
Yep.
it hurts you,
Right.
how much you want to take, and everybody's a little different on that. Yeah, the side effects are constipation, nausea, itching, and then just feeling kind of goofy in the head. Right? Those are the narcotic side effects. So we try to minimize narcotics, but we don't want to make you suffer either. So.
Okay. Yeah, last time I had no nausea. It was just the.
Yeah. I'm gonna give you some anti-nausea medicine just in case if
Right.
you do. But yeah, some people get it, some don't.
Okay.
Some people get constipation, some people get the itching.
Yeah.
It's all those are things that can happen with the narcotics.
Okay. That's
All
all
right.
I got.
So at 6 weeks, you do the remote follow-up and send it back to me. At 1 year, either come back and see me or do remote again. 2 years, same, just ion levels again at 2 years, and then every other year I want you to check in with me. So if you get a chance to come out here, please come and see me at some point.
Okay.
But otherwise, just continue with the remote follow-up every so often.
All right. Sounds good.
Okay.
I'm good. You good?
Anything?
All right. Well, thanks for watching my presentation, and I hope your hip resurfacing goes as well as mine did. Thanks.